Hello, I'm Matthew Gifford. Today in the MJ's Life Sciences and Medical World News, the Center for Biosimilars is pleased to welcome Brian Gifford, Research Director of the Integrated Benefits Institute. Can you just introduce yourself and tell us a little bit about your work?
At the Integrated Benefits Institute, for those of you who don't know, we are a nonprofit research and educational association, and we focus on workforce health and productivity. And what that means is we're the hub of a network of people who are really looking for ways to invest properly, invest wisely in the health of their workforce, not because it's necessarily the right thing to do, although of course many businesses tell us that that's one of the reasons that they make investments in health, but because that there is a longer term business proposition to it. So healthier employees, people who have well-managed conditions, for example, if they have chronic conditions, are going to be on the job more often, performing at a higher level. So we're always looking for ways to show business leaders that there's an advantage to investments in healthy workers. We'll usually focus on sick day absences, short-term disability leaves, but also on things such as on-the-job performance.
Can you describe rheumatoid arthritis and how it affects employee wellness?
One of the things about rheumatoid arthritis is, for a lot of people who have it, it could have some of the same symptoms as osteoarthritis. So for example, osteoarthritis is wear and tear on a person's joints as they age. It's going to happen to a lot of people. There may be a genetic component, but usually it's really just kind of old age, or you get aching, tender joints, stiff joints, and so on. With rheumatoid arthritis, it's a little bit different because you can have a lot of the same symptoms, but the cause is a little bit different. So it's when the immune system is actually attacking the lining of the joints for reasons that aren't really well understood. You get inflammation, for example, pain, stiffness. People will report fatigue. They'll report that they have not just one joint or two joints, but the same joints on both sides of the body. The causes, again, not really well understood. We know that there are some comorbidities around smoking and obesity. And very importantly, this can happen to anybody at a lot of stages of life. It can come on rapidly, and it can be pretty hard to diagnose. You know, it's like a lot of inflammatory diseases, Crohn's disease, ulcerative colitis, lupus, and so on. There are tests for it, but it can really come down to a diagnosis based on a wide range of symptoms.
Statistically, rheumatoid arthritis affects a relatively small population of employees, but the cost to employers and payers is disproportionately larger than for more common conditions. Can you explain this phenomenon?
Well, think of some of the conditions that we might compare it to. I already mentioned osteoarthritis, other musculoskeletal conditions like back pain. You're right that you're going to see those kinds of conditions show up a lot more often in a working population. Where we start to see the high cost of rheumatoid arthritis is in two different ways. One is, if you look at a population of people with rheumatoid arthritis compared to people without rheumatoid arthritis, and you do whatever statistical controls you need to do to account for comorbid conditions. This is where you start to see some of the medical costs go up. And this is for all kinds of treatments. And so, for example, one of the analyses we did showed that somebody with osteoarthritis compared to somebody without osteoarthritis is going to have $7,500 more in healthcare and pharmacy spending than somebody without rheumatoid arthritis. Excuse me. If you do the same analysis for osteoarthritis, it's going to be about $4,000. And for back pain, which afflicts a lot more people, it's going to be about $2,400. So overall, this is where we're really starting to see this high cost. And in fact, I should probably be a little more careful about my terms. I'm talking about expenses, right? So these are excess medical and pharmacy expenses. Cost is going to encompass a lot more things, right? And that's what a lot of IBI's work is about. But just in terms of what the healthcare system usually thinks about spending for treatments, and what employers often think about, yes, this is where we're going to see rheumatoid arthritis have relatively high expenses. They also, and then here's where the costs are going to come in. A lot of people will refer to these as indirect costs, but I would still say they're direct costs. Let's take sick days. The number of sick days that we can attribute to people with rheumatoid arthritis, in addition to what people without rheumatoid arthritis have, that's about $530 a year. So it's about 2.5 extra sick days. that people are not, or people aren't at work, they're getting paid. So that's an additional cost. I'm not really sure that that's high on the list of employers' concerns. And of course, one of the other things that we focus on at IBI are the longer term productivity costs. And this is going to be primarily in short-term disability leaves from work. So a lot of people have insurance policies paid for by their employer that says if you need time off to recover from an illness, for example, or to undergo treatments for an illness, or really just to get your, if you're having, for example, a really extreme bout of symptoms, you can take time off. You get paid about 60% of your wages, and you can take the time off you need to recover. And what we find is, first of all, for rheumatoid arthritis, compared to the population, we don't really see a lot of disability claims. And to me, that's probably some evidence that all of that excess spending on treatments is actually working to keep people on the job. But when they do have to take time off from work, compared to other kinds of conditions, again, osteoarthritis, back pain, other musculoskeletal conditions, this is where we start to see a really heavy burden in disability claims costs for rheumatoid arthritis. So yes, it's a small population, but it can be really expensive, both in terms of healthcare spend, but also in terms of productivity costs.
You described a hidden population of employees who may not be recognized as having rheumatoid arthritis and end up costing employers and payers, as you kind of just described. Can you explain what you meant by this?
So think about the difficulties in diagnosing rheumatoid arthritis. It could take a lot of testing. It could take a lot of interactions with doctors. But that doesn't mean that people who are undergoing symptoms of rheumatoid arthritis are just going to work through the entire time that they're being diagnosed. They might take short-term disability, for example, for some other cause. They might take it for, it might be diagnosed as osteoarthritis. It might be diagnosed as just some other kind of pain, especially if the arthritis is occurring in the back, for example. Ankylosing spondylitis. These are all kinds of things that people might be taking disability leave for. So when we find that if you compare it to the population of employees with rheumatoid arthritis, we find that disability claims are only about 1% of that population prevalence. And again, that could be good. That could be attributable to well-managed conditions, but it also could be that somewhere out in the rest of the population, there are people who are not getting the kinds of treatments that they need. They're taking disability time off, and the diagnosis that's being assigned to that disability leave is something else. Generic back pain, for example, generic joint pain. So employers who are really trying to get a handle on what's going on in their population, what's going on in their short-term disability system, they might not see rheumatoid arthritis. In fact, they only may see it when it's gone on long enough that the diagnosis has occurred and it shows up in their medical and pharmacy spend. So again, it's not really clear why, even given the small population of people with rheumatoid arthritis, it's not really clear why the disability rate is so low, given what we know about the symptoms of rheumatoid arthritis and its impact on people's ability to continue working.
Can you describe the value of anti-tumor necrosis factor drugs, particularly biosimilars, in helping control rheumatoid arthritis and keep employees on the job?
I can tell you what we learned from a review of adherence studies that we did back in 2018. So I combed the peer-reviewed research literature for studies that looked at medication adherence and people's time off from work for short-term disability and sick days. And we found a couple of studies on rheumatoid arthritis. We also had the advantage that one of the studies that we found through the peer-reviewed search was one that authors from the Integrated Benefits Institute had written back in 2004, I believe. And what we found was that for rheumatoid arthritis, people who were using anti-TNF treatments and who are using disease-modifying treatments, they had fewer episodes of short-term disability. And when they had short-term disability episodes, they were off the job for a less amount of time than people who are not adherent with these kinds of drugs. Now, in those studies, that's a pretty clear indication that people who have a well-managed rheumatoid arthritis case are able to stay on the job and be as productive as anyone else in the workforce. The challenge, though, for thinking about that in terms of biosimilars is that those studies, to my knowledge, did not include biosimilars. So they would have been biologics. And so for biosimilars to talk about the value in terms of lost productivity, I think what they have is a value proposition right now. They have the value proposition that they are very similar to biologic drugs. But as far as I know, there have not been the kinds of studies yet to show that in terms of getting people back to work, in terms of keeping people on the job, that they perform as well as biologics. I think, again, they have a value proposition to make in which they're chemically similar. They are similar in terms of their ability to return people to functional or functionality on the job or in other aspects of their life. But I always advise employers to look for the evidence. And so if there aren't studies right now showing that biosimilars compared to biologics, compared to usual source of care, have the same or different outcomes in terms of keeping people on the job, then what I would advise employers is ask for the evidence. Ask for it in terms of your own workforce. Do whatever kinds of analyses you can do, observational studies. I kind of take some of the same guidance that at the biosimilars event that IBI did with the Pacific Business Group on Health, a clinician from Kaiser Permanente, he made the comment that when they are switching to, for example, biologics to biosimilars, they make sure to track those patients who are now going into the biosimilars. And they do that tracking and they do that testing and they do that reanalysis, even though they've seen all the studies and believe all the studies that biosimilars can produce the same kinds of results as biologics. And I would advise employers to take that same approach. You've seen the evidence that these are going to produce similar kinds of outcomes in different populations, but you really want to know what's going on in your own population.